Well, it is my great pleasure to introduce Dr. Indra Narang and Lena Xiao, and I will just read their introductions and hand over to them. Dr. Narang is a Senior Associate Scientist at the Hospital for Sick Children in Toronto and an established clinician researcher in childhood sleep disorders. She established the first dedicated narcolepsy clinic for children in Toronto. Her research focuses on the multidisciplinary approach to children with narcolepsy, as well as targeted approaches to obstructive sleep apnea in children. Dr. Lena Xiao is the Chief Pediatric Respiratory Medicine Fellow at the Hospital for Sick Children in Toronto, Canada. She completed her Doctor of Medicine at the University of Saskatchewan and her pediatric residency at the University of Ottawa, where she was also the chief resident. She has a special interest in pediatric sleep-disordered breathing and narcolepsy. Well, thank you both for joining us. I'm very excited to hear your presentation. It's nice to see you both.
Thank you so much.
Lena, do you want to unmute? Thank you.
Thank you so much to Claire and Wake Up Narcolepsy for inviting us to present today. And as always, I truly want to acknowledge the support for Wake Up Narcolepsy, because some of the research that I will show you today would not have been possible without funding from Wake Up Narcolepsy and with their ongoing continued advocacy of the work that they do for the children and families that we serve here in Toronto. So I'm hoping that you can all hear me. And I'm going to start off with this presentation, and then Lena, Dr. Xiao will take over halfway through. Next, Lena's going to be controlling the slides. The next slide, please. I've already talked about the Unrestricted Education Grant. So the first study that I will talk about is this study published in Sleep in 2019 by my master's student at the time, Peter Palmer, and it's regarding depressive symptoms, sleep patterns, and physical activity in adolescents with narcolepsy. Next slide, please. And you know, we've been long interested in, you know, the mental health of the patients that we serve in our clinic here in Toronto. And maybe I'll just recap and tell you that in around 2011, I only had one patient child with narcolepsy, and our clinic really grew following 2011. And so for us, you know, with the parents and families, this was our joint journey where we learned from them and they learned from us. And so one of the things that we learned along the way was, you know, as we were treating the symptoms of narcolepsy, we began to really understand more about the mental health of some of the children, but especially of the teenagers here. And so we wanted to understand more, particularly around the depressive symptoms in narcolepsy. And I think we all appreciate now there are increased number of data to show that the prevalence rate's around 12 to 40%. And we've begun to understand a little bit more that, you know, what the relationships with depression might be with regarding sleep duration, sleep quality, excessive daytime sleepiness. And there really wasn't anything about what the relationship might be with physical activity. So next slide. And so the aim of Peter's actually master's thesis, so she spent 2 years doing this study, is to determine if sleep quality, excessive daytime sleepiness, physical activity were in fact associated with depression in these children. And the aim was to compare that to otherwise healthy controls. And Peter hypothesized that actually all of these factors, so sleep quality, sleepiness, and lower levels of physical activity, will be associated with depression scores. Next slide. Now, this was the framework for the primary objective, which was looking at, you know, the depression scores and the factors that we wanted to evaluate here, which I've just mentioned. But also we had to take into account our covariates, particularly obesity, age, and sex, which we know will impact all of the sleep factors as well as physical activity that we're going to talk about, but also can independently affect our primary outcome, which was looking at depression scores. Next slide. So this was a case control study design, and really what I mean by that is that we took a group of adolescents with narcolepsy and we compared them to controls. And we recruited our children through our own narcolepsy clinic here and controls from a local high school. And I have to say thank you to our patients and families here. Our adolescents with narcolepsy were much easier to recruit than controls from the local high school. And so we included everybody 10 to 18 years of age, and we excluded anybody who was actually known to have depression or anxiety, and also known to have other sleep disorders such as obstructive sleep apnea, because we know that that can be an independent risk factor also for depression. And although our controls didn't have a polysomnogram, anybody who had any symptoms of obstructive sleep apnea were also excluded from this study. Next slide, please. So what did we actually do? Well, we took our 30 adolescents with narcolepsy and 30 controls, and it was really quite a comprehensive study where they were asked multiple questions regarding mood, for example, self-esteem through this children's depression inventory scale, CDI-2. We asked about their Epworth sleepiness scale, their quality using this Pittsburgh sleep quality questionnaire. We measured questionnaire physical activity actually just through a pedometer and also a questionnaire. We looked at quality of life, and we measured sleep duration and sleep quality as well using this actigraphy that was worn for 7 days. Next slide, please. So we undertook this study and that whole process in all of the 30 adolescents with narcolepsy, as well as our 30 controls. And just to show you some of the differences here. So our controls were slightly older than our adolescents with narcolepsy. There was, even though it looked like there was more males in the narcolepsy group, this was not statistically significant. The BMI, so the weight, was a little bit higher in our group with narcolepsy, and we saw more children who were classified as obese in the narcolepsy group compared with our controls. What was certainly statistically significant was the racial variation of our narcolepsy group compared with our controls, meaning that specifically we had actually less white adolescents compared to the control group. And 76% of our group were on medications. Now, that doesn't mean, by the way, I just want to be clear about this, that we knew that they took their medications, but we know that they were prescribed medications. And so just looking at what our children or adolescents with narcolepsy looked like, well, not surprisingly, 100% had EDS, and cataplexy was in around 3/4 of the group, with sleep paralysis around the 17%, and hallucinations reported in about 10% of this group. Next slide, please. And so I just wanted to go through just some more of this actual data that we collected from this group. So the Epworth sleepiness scale was 13, and as many of you know, more than 10 suggests excessive sleepiness, and our controls had a much lower score for Epworth sleepiness scale, not surprisingly. We then looked at the sleep quality using that questionnaire, the Pittsburgh questionnaire, and I don't know if any of you are familiar with it, but we've actually used it in a cohort of 4,000 adolescents here in Toronto. And it does discriminate between sleep disturbance and no sleep disturbance, with more than 5 really suggesting poor sleep quality. And as you can see here in the narcolepsy group, the mean score was 5.7 compared to the controls, who were much lower. And 50% of our group actually in total had a score of more than 5 compared to only 1/4 of the group with the controls. Our children with narcolepsy had a much lower sleep time over the 24 hours as measured by actigraphy, but also by their sleep diary. And again, not surprisingly, sleep efficiency, so how good their sleep was and how many times they wake versus not waking, was lower in the narcolepsy group compared to the controls. And so when we actually went and looked at our depression scores here, you can see that, so this depression score we used was the Children's Depression Inventory 2, which I've mentioned, right, looks at self-esteem and how individuals function, and interpersonal problems and so forth. And a score of more than 13 is considered clinical or indicative of clinical depression. And here we can see that the score in the narcolepsy group was higher at 10.7 versus the controls at 6.7. And when we broke that down a little bit, we found that almost a quarter of our adolescents with narcolepsy met the clinical criteria for depression. And just to highlight again that none of these adolescents were known to have depression. Next slide again. And again, when we looked at our physical activities, we found that, when we looked at the pedometer or the step count, it was pretty similar in our narcolepsy group versus the controls. But when you actually asked our adolescents with narcolepsy, they felt like they actually participated in less activity than the controls. And certainly our adolescents with narcolepsy were less likely to be in the active range compared to the controls. Next slide. And so we're already seeing, as I've just highlighted here, so more sleepiness, poorer sleep quality, less sleep time, less sleep efficiency, and lower levels of physical activity in our adolescent narcolepsy group. And when I actually compared that to the CDI-2 scores or the depression scores, you can see here that poorer sleep quality, sleepiness, and lower levels of physical activity actually were significantly associated with having a higher depression score. Next slide. And similarly, this just highlights the same, that even taking into account all of the obesity and the age and the gender of our participants, these three factors were significantly associated with having higher depression scores in our adolescents with narcolepsy compared with our controls. So just in summary here, we found that higher rates of depression were found in our adolescents with narcolepsy. And the reasons behind that were linked to sleep deprivation, whether that through decreased sleepiness, decreased sleep time or being excessively sleepy, but certainly poorer sleep quality, as well as lack of physical activity. And, just a little bit, I know that there's quite a lot of data out there or emerging data around mental health in our adolescents with narcolepsy, but this was the first study that actually had looked at the sleep and the mental health and the physical activity in one study and trying to, disentangle what were the contributing factors towards depression. And, this was also a study was good in the sense that we had objective measures of both sleep and physical activity, and we were able to collect these data in a control group as well. I mean, like anything, there's a cross-sectional study design, which really does limit, I think, some of this data. And we had a relatively small sample size, so it did limit some of the subgroup analyses that we would have liked to have done, for example, in children who were taking medications versus the children who were not taking medications. Next slide. And we really wanted to explore the physical activity a little bit more. So why would physical activity contribute to, or lack of physical activity contribute to increased depression? So, or vice versa. And we know that physical activity may be a distraction from negative thoughts or rumination. And certainly what COVID has taught us is that, the more social interaction that you have, be that through physical activity, in-person school, you have that real sense of connectedness and belonging, and therefore you're likely to have an improved mood. So was that some of what was coming out in this data, that, if you're less likely to participate in physical activity, it did impact your mood? Or is it simply that, if you have a low mood anyway because of your inherent illness like narcolepsy, are you less motivated to take part in physical activity? And I think all of us can also appreciate, again, during COVID, when, we probably haven't had optimal mood, I think the last thing we wanted to do is to say, okay, we're going to go out there and just do lots of exercise to make ourselves feel better. So I think it's probably a bidirectional relationship that we have to consider. Next slide. So why might sleep deprivation also be linked to depressive symptoms? We don't 100% know, but we know that there's data in healthy adolescents that sleep deprivation may disrupt your emotional regulation. And also, we also know that inflammatory pathways, which are implicated in depression, may also be implicated in scenarios where you have sleep deprivation. But clearly, what is needed here is to really better understand the pathways implicated in depression in adolescents with narcolepsy. And I just feel like, really addressing the mental health of adolescents in this study was just the tip of the iceberg. That being said, I think one of the other things we learned from this study, this is this is quantitative data, data collection. But I think if there's one thing that we really know that we need in all of the research that we undertake is that we need to hear the voice and the perspective of the patients and families that we serve. And without that, we don't fully understand the problem. So it's okay doing surveys and everything, but what do our adolescents really think about their experience, their mood, their participation in physical activity, why they do and do not take medications? So I think at the end of that study that our Peter undertook, even though we had looked at ways to change our clinical practice, and we have done that. So we have an adolescent medicine specialist who's part of our narcolepsy clinic and evaluates all our adolescents for, their interactions with peers, their mood and depression and so forth. What we didn't feel that we could do is really embed even a more holistic approach in our clinic without talking to individual adolescents and with narcolepsy. And so an extension of that study was the voice of the adolescents and qualitative data that we subsequently undertook as an extension of that study, which Dr. Xiao will talk about now. And then maybe when she's finished, we're happy to take any questions, unless there's any questions now.
All right. I don't think so. Let's move on with Lena and then collect them at the end.
Okay, thank you.
Thank you.
All right, perfect. So I'm happy to be presenting today and sharing some more results from the qualitative study that we undertook to better learn about the lived experience with narcolepsy from adolescents. So I'll be presenting the key points from our two studies on this. And what we'll be looking at today include mental health, resiliency and coping with narcolepsy, and then learning more about the adolescent experience with treatment for narcolepsy, including the experience with medications and behavioral strategies. So in this study, we interviewed 18 adolescents aged 10 to 17 years old with narcolepsy at the Hospital for Sick Children in Toronto, Canada. The average age of diagnosis for this cohort of children was 14.4 years, and 56% had cataplexy. We also had 33% with sleep paralysis, 50% with hallucinations, and 72% with poor nighttime sleep quality. The other comorbidities in this group included anxiety, depression, OCD, and ADHD, or attention deficit hyperactivity disorder. We also looked at the experience with treatment of narcolepsy. And in our group, there were 13 patients who were taking medication, and 5 of these children were taking more than one medication to control narcolepsy. On the other hand, there were 5 children who weren't taking any medications for narcolepsy at the time of the interview. So first, we learned about how adolescents perceived narcolepsy and the symptoms from narcolepsy. So the main symptoms that we explored and we heard about were excessive daytime sleepiness, cataplexy, hallucinations, sleep paralysis, and dreams. So excessive daytime sleepiness was the first recognized, and it was the most frequently reported symptom in our group. And oftentimes it was excessive daytime sleepiness that really triggered the diagnostic process and final arrival at the diagnosis of narcolepsy. Our participants described it as an urgent need to sleep throughout the day And it was really characterized by this wave-like nature of sleepiness that came and went throughout the day. As one participant said, normally there's like a weight on my eyes. Sometimes it's heavier, sometimes it subsides, but I know it's there. And if I lay down, I'm gone. When it comes to cataplexy, this was described as a negative symptom by everyone who did describe it. So some adolescents described it as a minor inconvenience that was easily hidden, but others spoke about cataplexy as one of the most challenging parts of having narcolepsy. Similarly, all adolescents who had hallucinations also described the experience as scary, especially when the line between reality and perception became blurred. Sleep paralysis was also associated with extreme fear. It was described as frightening and frustrating when one, lost all control over their own body. And for some, sleep paralysis was the most feared symptom of narcolepsy. Lastly, when it came to dreams, many participants felt quite positively about it. And some discussed looking forward to dreaming and even described the therapeutic role of having vivid, amazing dreams. We also learned a lot about mental health concerns from our adolescents with narcolepsy. And unfortunately, this was perpetuated by many different things, such as a lack of support and awareness of narcolepsy, which often led to misconceptions and stigma. There's a lot of information on the slide, but we're going to go through each category slowly here. So to start with, the most commonly reported mood change was increased irritability, and this was associated with excessive daytime sleepiness or poor sleep quality. Unfortunately, many adolescents reported that they avoided social interactions as a protective mechanism so that they wouldn't lash out or be irritable with their family or friends. Several adolescents also reported being embarrassed by their narcolepsy symptoms. And the most embarrassing symptoms that were reported were sleepiness and sleep attacks, as well as cataplexy. Unfortunately, there was also this association that we saw between embarrassment and with reports of bullying at school. Adolescents also describe frustrations with dealing with their symptoms and feeling unsupported or misunderstood by those who are around them. Part of their frustration stemmed from feeling alone and having narcolepsy, or feeling like no one understood what it meant to have narcolepsy. And then the last main category was worry about coping with narcolepsy as adults. The biggest worries that we heard from our adolescents were about obtaining jobs, developing relationships, gaining independence, and having the ability to drive a car in the future. In addition to the mental health effects of narcolepsy, we also learned a lot about adolescent resiliency and how they coped with having narcolepsy. In our group, there were some adolescents who reported a good attitude toward narcolepsy, and this was facilitated by many different coping strategies. One of them was about being able to incorporate narcolepsy into their identity. And it helped when patients were diagnosed at a younger age or when they had a longer time of diagnosis in order to be able to incorporate narcolepsy into their identity. And this allowed them to adjust to a new normal. So although many adolescents talked about the initial gravity of the diagnosis, many were able to accept the diagnosis over time and redefine the magnitude of narcolepsy on their life. So as one patient said, narcolepsy is a thing you have to accept that's happened to you. It's also not the worst thing in the world, and it's something you can get used to. You can still live a good life with it and be as happy as a normal person. Other facilitators that adolescents described included positive relationships with parents, the support of friends, and school accommodations. So when it comes to treatment, our adolescents described both medications and behavioral strategies as being quite useful. The first thing is that medications are moderately effective, and this was reported by the majority of adolescents who were taking medications at the time. Some adolescents were able to cope with narcolepsy symptoms while on medications, and others felt that they could not function without medications at all. And still another participant here described that medications really helped them to stay in a good mood. So although medications were effective for many adolescents, it was also recognized that medications are not a perfect fix. There were still residual symptoms of narcolepsy even with medications. For some participants, the lack of a perceived effect was also the reason for stopping or discontinuing medications altogether. When it comes to medications, adolescents do have many concerns about taking them. So there were concerns about side effects such as headaches, changes in appetite, weight loss, and a depressed mood. Some adolescents were also concerned about starting medications because of the risk of becoming dependent on medications later in life. So recognizing that there are a lot of risks and benefits that come with taking medications, a lot of adolescents talked about wanting to be more involved in the treatment decision-making process, and also highlighted the importance of really good counseling and discussion about the possible side effects before starting the medications. So in addition to medications, we learned a lot about the perception on behavioral strategies as well. Many of our adolescents talked about using different behavioral strategies to address the residual symptoms of narcolepsy, even after taking medications. And really importantly, something that we heard over and over again is that adolescents were learning behavioral strategies through personal trial and error. So one of the things was that although behavioral strategies are helpful, it's not always the same behavioral strategies that are helpful for each individual. And that's why a really personalized process of learning about their own behavioral strategies that were effective was important in this process. So the different strategies that we heard for excessive daytime sleepiness included intermittent rest, which was characterized by short naps throughout the day in order to boost energy levels, as well as physical stimulation like regular physical activity, or even stimulation when patients were starting to feel tired. So things like splashing water on their face. And then different approaches to mental stimulation were also discussed. And we heard from many adolescents that engaging in activities that they find personally stimulating and exciting was really quite helpful for preventing sleepiness. There were also different types of strategies described to deal with cataplexy, and they mainly fell within these two different categories. So the first category was changing body position just before the onset of cataplexy to reduce how dramatic the cataplexy episode was. So patients described leaning on different structures to avoid falling on the ground. And this one participant described stiffening their legs before a cataplexy episode. The second primary strategy that was described was avoiding cataplexy triggers. And so the quote here is from one patient who very eloquently stated that he lost his laugh as much as possible and stopped crying. And in his words, "I cut all of it off. To me, it was a wrong decision when I was younger because it cut me away from a lot of people." Lastly, many adolescents described the importance of regular psychosocial support. And this included a desire for a multidisciplinary healthcare team, including psychology and social work. It also included a desire to have a platform for adolescents or their parents to connect to talk about different narcolepsy treatment strategies. So we learned a lot by sitting down and speaking with adolescents about their experience with narcolepsy. These interviews really highlighted that although medications are a first-line treatment for narcolepsy, they're not fully effective and may be associated with troublesome side effects. At best, medications were there to alleviate symptoms of narcolepsy. So for this reason, it's really important to have adolescent engagement in the decision-making process, and to also set targets and goals for the symptoms that are the most troublesome to them, and titrating medications in order to meet their goals for those symptoms, and then also monitor for side effects of medications. It was also evident that behavioral strategies are a really important part of narcolepsy treatment. And for this reason, it's important to have different platforms available for adolescents to talk about behavioral strategies so that they can share their own experiences with one another. It's also important that physicians engage more in the clinic setting about discussing behavioral strategies for patients. We also heard a lot about the importance of a biopsychosocial framework to the treatment of adolescent narcolepsy. So having a really holistic and comprehensive program of education, counseling, and pharmacological intervention in order to fully address the symptoms of narcolepsy. So it's important that mental health supports are regularly incorporated into the care of adolescents with narcolepsy, and that a multidisciplinary approach is taken, including sleep medicine, psychiatry, psychology, social work, adolescent medicine. So lastly, I just wanted to thank the sleep medicine team at the Hospital for Sick Children for making this research possible, and of course to all of our families and adolescents who were involved in our research projects. All right, so I think that we would love to take this opportunity to answer a few questions.
Yeah, thank you so much. That is extremely thorough and helpful. And we do have questions, so I'm going to, in the interest of time, just jump straight into those. So one question is, if joy is a cataplexy trigger, how do you keep kids from cutting off feelings and trying not to feel joy?
Do you want me to take that question?
Sure.
Yeah. You know, I've been quite concerned about some of the children who say how they limit laughter, they limit fun because they're worried about the cataplexy, and especially with some of our adolescents, right, who don't want to perceive to even look different amongst their peers. And I really have started to tell them, you know, there are so many, we're all different. There are so many variations of what is normal and not normal. There's so many different diverse perspectives. And I think you have to be authentic, and, you know, you have to be who you are, be that at home and at school. And, you know, we're learning as a society that we all need to be more inclusive. And what does that mean? We need to be more accepting, right? Somebody who has narcolepsy isn't really different to me who doesn't have narcolepsy, right? And so how do we do that? And I think it's a lot of education to our children and families, but also people who don't have narcolepsy. I think that's a really important part of it. I think peer support becomes really important, but also addressing these issues in a really holistic approach when they come to clinic, and having those conversations with the adolescent medicine specialist around coping and how do you cope in these scenarios. So I think it's really taking that multifaceted approach. And of course, you know, the biggest allies of these children are their families, right? The families who tell them, you know, it's okay because we're here for you. So I think it's really taking a much broader approach and making sure that they get to do the things that they want to do, because the goal of children with narcolepsy, or our goal as healthcare professionals, is that everything is normalized as much as possible and that they have a normal quality of life.
Thank you. Similar sort of related question. Are you aware of psychologists specializing in sleep disorders working with adolescents following their diagnosis? I know that as an adult, there are lots of psychologists, but not many that are aware of how sleep impacts that in children.
That is a great question. And actually, we have been advocating for a very long time that, you know, we need psychologists. I have to tell you, not just for my population with narcolepsy, but all for my other sleep disorders, because sleep is a key fundamental part of your life, right? Lack of sleep, and, you know, I think of it as the pillar in the same way that we think of physical activity and diet. It really is critical. But you're absolutely right that, you know, there's a couple of psychologists who work with children and their focus is sleep disorders, but it has been a challenge, certainly for us in Canada, about finding psychologists where this is their primary foci.
Yeah, so if you can't access a psychologist then within the umbrella of a sleep department, do you advise patients to, or parents to, seek counselling, support services kind of privately? What would you recommend?
So, you know, we don't have, again, I don't know where the audience is from, but we don't have much option here in Ontario except to refer them privately. I mean, as our adolescents will see our adolescent medicine specialist, and then we have to refer privately. But I think that putting supports into place really early on has long-term benefits.
Okay.
Thank you. So this might be a question that I can answer actually. Are there any support groups for teens and adolescents with narcolepsy? But do you have support groups locally?
We don't actually have support groups locally. We have very much relied on redirecting our children, our families to Wake Up Narcolepsy. And sometimes they've been able to have, individual peer-to-peer support, which we found very helpful. It is something that we have talked about for a while, and it's something that we want to do. But right now, it's Wake Up Narcolepsy is our main support. Thank you.
Yeah, no, so we've actually, this is great timing. We're about to launch a virtual support group. We do run support groups throughout the year. Next month, we're launching a teen specific. So that's 13 to 17-year-olds. And the group's going to be led by 2 girls with narcolepsy. They're the mid to late 20s. So this is a free support group. And for those of you out there with children that fall into that age range and would like to attend, just go to our website and you will see support services, support groups. Also follow us on our newsletter and social media, because we will do announcements. So that's a teen support groups that starts in a month. We also offer a camp for children. That's from 4 upwards with families. The whole families can go. It's in Kentucky. Again, we will be announcing more about that. Registration is free, and we all get together for, I think, a whole weekend at the end of August. So that's Camp for Children with Narcolepsy in Kentucky. And for parents listening, we run a group for caregivers and parents called Conversations. That's on a Monday evening every month, led by myself and Lindsay Jedstadt. We're both parents of, Lindsay's son is a preteen, my daughter Matilda is 14. So we actually have a lot of parents attend, and you're very welcome wherever you live, whether it's Canada or elsewhere. So please do join us for Conversations. I had a question actually way back for you, Indra, at the beginning. You said that in 2011 you had 1 patient with narcolepsy and then it changed. Why do you think that happened, that you suddenly saw, presumably you saw an influx of children with narcolepsy?
Yeah. We've never really been able to ascertain exactly why that happened. As you know, around that time, there was the H1N1 situation. And one of the things we've always questioned, right, was it the H1N1 infection? As you know, there was a lot of talk in Europe. Was it the H1N1 vaccination that had the different adjuvant, for example, to the vaccination that was given in the US? Or was it awareness? There was a lot of awareness around that time about excessive sleepiness, hypersomnia, narcolepsy, especially coming out of China and Europe. And certainly at that time, there was a lot of pediatricians who I want to say were very aware. So was it a combination of those factors? Probably. What I can tell you is that we also had, around that time, we conducted pediatric sleep symposium in Canada, which attracted more than 200 delegates. Actually, 150 were just from Canada alone. And right after that, we saw an increase in all our referrals, both for obstructive sleep apnea and narcolepsy. So was that related to awareness? Probably. And I can also tell you that when a pediatrician referred as somebody and they said query narcolepsy, at that time point, there was 80% chance or 85% chance of the pediatrician being correct, which is very, very high and something that we hadn't seen before either. So I want to say that a large part of it was awareness. I really can't talk much more about the H1N1 influence because I think, the jury's still out.
Mm-hmm. That's helpful. Is there still sort of a success rate of 80% with your referrals, would you say, or was that?
I think it's even higher.
Oh, good. Okay.
Yeah, I would say that by the time a pediatrician refers to us, now they get fast track because you read the history like, okay, they probably have.
Mm-hmm.
In fact, the pediatrician's now right. I think this is narcolepsy.
That's a big shift, isn't it?
It's a huge shift.
Yeah.
It's a huge shift.
Right. Okay, I have another question. Who might be able to help a child determine what behavioral strategies to use?
So I think that there are a few different avenues here. Like we were talking about, having those platforms for adolescents and children to speak with one another about their experiences with narcolepsy, I think could be very helpful. We also heard from some of our participants that they learned about behavioral strategies from their mentors who had narcolepsy, who were able to describe to them what they personally did. And then these adolescents would take those learnings and kind of incorporate it and try it for themselves. I also think that physicians have more of a role to play in describing different behavioral strategies. So in clinic, I think that physicians can help guide patients by describing what other patients have tried and have explained as being helpful for narcolepsy, whether that be for sleepiness or for cataplexy. And then what many of our patients highlighted is that they had to try it out for themselves because there were strategies that worked for some and not for others. So there is that personal learning process to it as well.
Thank you. You did mention a lot the correlation, that bidirectional correlation between exercise and depression. What would you say to a teenager who is very reluctant to be active?
Probably what I say to all of the kids. It's like, go out there. It's time to get active. The days are longer. The weather's warmer. You know, my message is honestly similar to all children and adolescents. You know, just like sleep is really important, so is physical activity. Physical activity has so many benefits. Certainly we're understanding the benefits on mood, but also just on your general health, right? Be that cardiovascular health, metabolic health, multiple benefits, and obviously weight control as well. So I try and motivate children as much as possible. But one of the things that I have to tell you that we also realized from that study and another study that we're doing is that you are much more likely to participate in physical activity if your family participates in physical activity. So just like making, you know, sleep a priority in your family, so everybody having really good bedtimes, right, and having a really good amount of sleep, it's the same for physical activity. If the whole family participates in physical activity, it is hugely beneficial to the children in that family.
Yeah, thank you. It's been such a privilege to help support your work through funding, and I would like to invite our audience to continue to fund Dr. Narang's lab and her research, and you can do that by going to our website and pushing the donate button, and you have an option to donate to either services or specifically for research, and 100% of our funds for research go to research. So what's next, Dr. Narang, for you?
Yeah, so you know, we recognize that there's a huge amount of work to do. One of the things that I think would probably be helpful for our group is to really ascertain how beneficial physical activity is. And I don't just mean on mood, although that's important as well, but just their overall health. So we've also seen some adolescents with narcolepsy were a little bit on the heavier side, you know, with regards to their BMI. And so our next step is we're looking at doing an intervention study and looking at the impact of physical activity. So a randomized control trial looking at the impact of physical activity on sleep quality, daytime sleepiness, mood, and weight. So that's our next step. If anybody here wants to participate or certainly donate to our research, we would be very, very happy to hear from you. And of course, as always, we are very grateful to Wake Up Narcolepsy for the funding for our work.
So another thing is that when researchers like yourself come to us with a trial, a clinical trial, we put that on our website. I will be speaking about live clinical trials at the end of this morning's or this afternoon's webinar that are Canadian specific, but do follow us on our social media feeds and our website, because you will see opportunities for clinical trials, and it's another way we work with our researchers. It's always a pleasure to speak to you. Lovely to meet you, Dr. Xiao, as well. Thank you, thank you. And keep us posted on your research, because it's really, really important, and we're so grateful that you're doing that type of work.
Great, and thank you again for allowing us to present our work.
Thank you.
Thank you so much.